Welcome once again to The Radical Imagination. I'm your host, Jim Vrettos. On July 14th, 1970, the New York Young Lords, a revolutionary community group composed of young Latino and Black New Yorkers, occupied Lincoln Hospital in the South Bronx for 12 hours, demanding better care, improved conditions, and a variety of patient and worker rights for the communities of color that the hospital served and employed. The hospital had become a symbol of all that was wrong in healthcare facilities in inner city communities. While these demands for a people's hospital were made more than half a century ago, their relevancy for New York City remains undeniable. Death rates are 30% higher in the poorest New York neighborhoods than in the wealthiest ones, which also have much higher life expectancy rates. Nearly 3/4 of emergency room visits in New York City for the poor were for non-emergent healthcare needs or could have been treated in a primary care setting. Access to healthcare continues to be a profound issue as the cost of living in the city has forced many New Yorkers to opt out of insurance because of high costs. That's just the tip of the iceberg. Since 1965, the East Harlem Council for Human Services has attempted to make a dent in these statistics, providing fully bilingual health and human services to the underserved East Harlem community. We're honored and blessed to have Dr. Adam Aponte on The Radical Imagination today. He's the Chief Medical and Executive Officer for the Boriken Neighborhood Health Center, located in El Barrio at 123rd Street and 3rd Avenue, just about 20 blocks from our studio. He's gracious enough to visit us today in person on the show to explain the comprehensive service and treatment plans of the patient-centered medical home he directs, with a staff fully knowledgeable and aware of the community they serve to provide the best possible health care for El Barrio. So, can I call you Adam?
Absolutely.
Okay.
That's what my mother calls me,
All
except
right.
when I'm
Well,
in trouble.
All right. Well, you're not in trouble here. We're friendly environments, but thank you so very, very much for being on the show. And you know, I've driven in the area. I've walked around. I'm so glad to know more about your facility. Sure. It's been around since 1965.
1965.
But you haven't been the director since that. You're too young for that. But tell us a little about how this got started. We were talking a little about the war on poverty in the 60s and community health centers and so on. So this is a vitally important facility for, as I said, an underserved community.
Correct.
So necessary.
Correct.
How did we all get started on this?
Yeah. Well, thank you for the invitation, first of all, and appreciate any opportunity we get to shine a light on the work that we're doing, and not just us, but what we describe as the FQHC movement, Federally Qualified Health Centers, which is what we are designated as. So, you know, just to go back, as far as Federally Qualified Health Centers, I'll give you that context first.
Okay.
These were created in the 60s. This was the war on poverty under the Johnson administration, when there was a recognition that we needed more health services in certain communities. And so as part of that war on poverty, the Johnson administration created these community health centers. The first of which, the two were in Boston and in Mississippi. And one of the founding fathers of this movement was Dr. Jack Geiger. Many folks know Dr. Geiger with his work in terms of community health centers, and realized that it's better to get into the community to provide health care than to sit in the brick and mortar of a hospital and wait for folks to walk through these sort of outpatient settings.
Yeah.
Really
and not getting the care they needed, leading to people like Felipe and
Correct.
the young lords
not getting the care that they need, getting very fragmented care,
Exactly.
not providing comprehensive primary care services. I mean, hospitals are great for emergency stuff. Hospitals are great for, when you need surgery, but they're not so great when you need basic fundamental primary preventive care services, which is the focus of FQAC such as ours.
I see.
So the movement started back in the 60s and continues today. Today there are about 1,400 FQACs nationwide. They serve about 31.5 million individuals. That means 1 in 11 individuals in this country get their care at FQHC. In New York State, we serve about 2.3 million individuals in New York State alone, which is about 1 in 9 individuals. And if you look at statistics and you look at poverty levels, you can argue that 1 in 3 Americans should be eligible for healthcare and community health centers. And that's something that we're sort of focusing on, making sure that we capture everyone. Everyone gets the right to healthcare. We believe in that right to healthcare, not a privilege. So the East Harlem Council for Human Services, which is our corporate name, was founded similar to many things in this community. Grassroots efforts, people came together around the time, started focusing on the social issues.
Again, this is back in the mid-'60s.
This is the mid-'60s, correct.
Okay.
This is actually probably about 1964 or so when the group got together, a group of individuals from East Harlem, and said, what do we need to do better for our community? We need to really take care of ourselves because we're not being taken care of by others. And they focused again on a lot of social issues. Some things that we talk about today, just poverty, crime, poor housing conditions, all these things that today people might describe.
Structural violence that poor people were experiencing.
Exactly.
That manifests itself certainly, obviously, in medical and mental health issues.
It leads to a lot of these
Crime,
issues.
violence, all kinds of things.
They're all interrelated.
Nutrition,
They're all interrelated.
Yeah.
And so they focused on that. And one of the very first programs actually that we created was our bilingual Head Start program, which, by the way, also was a program that was funded under the Johnson administration during the war on poverty to get children access to, or parents access to early education. And so we still run our bilingual Head Start programs. We have 2 programs in East Harlem, one on 116th Street and 111th Street that we've been running. It's very unique because it is a bilingual program, and we felt that that was very important in the East Harlem community. We all know East Harlem is traditionally a Latin community. At that time, it was mostly people from Puerto Rico. Now we have a whole potpourri of folks from Spanish-speaking countries that live in this community, but it's predominantly still a Spanish-speaking community.
Sure.
And then shortly thereafter, folks realized that access to healthcare was also limited. And at that time, despite the hospitals that surrounded us, Metropolitan Hospital, Mount Sinai was
on 100th Street.
Yeah.
So it started with Head Start.
It started with Head Start.
And began to grow and see the need for other.
Correct. It created other programs based
Right.
upon, again, what they felt the needs were.
Got it.
And a big need was healthcare.
Right.
And again, the hospitals at the time, Metropolitan, Mount Sinai was just coming into community, Harlem Hospital was here. There was a hospital at that time called North General Hospital. And then if you want, you can talk about Lenox Hill, although Lenox Hill, as we know,
That's
is in the
further
Upper East Side and
south.
really
That's
didn't
different.
take much care of this community at that time. Now,
So it was nothing really from 96th Street to 125th Street. What did you have?
very few providers. I mean,
Right.
we all know what happens when you cross the double yellow line, 96th Street, and you go from Upper East Side to East Harlem. I mean, you walk downtown 96th Street on Park Avenue, every other block you see shingles of private practices and doctors all over. And when you walked further uptown, it didn't exist.
Right.
So everyone got their care in these hospital settings, which were woefully inadequate to meet the needs at the time. So the council created the Boriken Neighborhood Health Center, which still stands today. It's over 50 years old as a health center. Started out of Wagner Projects. That was our first sort of home, if you will. Then we moved into tiny.
And still exists. Where is this now?
So our health center is currently on 123rd and
123rd.
Yep.
Okay, so it's affiliated with Wagner and
No, it
I'm
was.
sorry.
It came out of
It was.
Wagner House.
Got it.
So
Okay.
our first place, our first home was
Right.
Wagner Houses. Right?
Okay,
So
got
we
it.
found space there. We created the health center. Probably it was maybe a tenth of the size it is today, correct, right?
Okay.
And
Got
then after that, we moved into Taina Towers, which is on one, that was a new development that came in the 70s. So we got some space there. We were there until 2014. And in 2014, through some secure funding that we got, we were able to move into our current building, which is on the corner of 123rd and 3rd. So 2265 30th Avenue is our current location for the health center. And
it's a big facility.
Yeah, it's 5 floors.
And I'm going to visit it May 1st.
Yes, we're looking forward to your visit.
Look forward to that.
We're very pleased with the place. We were able to really make it feel comfortable. People walk in there. People often describe these locations as clinics. We're not a clinic. We're a comprehensive health center. And the reason I say that is because as a kid who grew up in East Harlem, so I'm an East Harlem kid, used to get my care at Metropolitan Hospital, Mount Sinai's emergency room. We know what a clinic was like, right? A clinic at that time, you showed up an appointment. You had no appointment. You showed up at 8:30, 9 o'clock. You got online. You sat for 3-4 hours. As kids, we didn't care because we ran around the waiting room and we had fun. But my mother was there with, there were 7 of us. Right, so imagine she's got 5 or 6 kids going to see the doctor. She's there all day long. We got in to see the doctor. The vast majority of any of them spoke any Spanish, so there was no interpretation service at the time. When you want an interpreter, you grab somebody from the waiting room, right? And then they would talk to her in English, see us for 15 minutes, and send us on our merry way. Right? And that's the clinic. What we do is so far beyond that. We are what truly was called patient-centered. We envelop our patients in the care that they need, whatever they need. And so
let's say someone comes in, walks in. Let's make up they have diabetes.
Sure.
And take us step by step.
Right.
So let's a 35, 40-year-old Puerto Rican woman.
Right. So one thing that's important about us is that we see all patients regardless of their ability to pay, their immigration status. So if you don't have insurance, we still see you. We have something called a sliding fee scale that we base it upon your income level. And some people who are 200% below the income levels, poverty levels, then they pay essentially almost nothing for the care there.
Right.
We're funded by the federal government in order to do that. We are a safety net. And so an individual...
No hassles on that.
No
so
hassles.
People who don't have the money walk in, they'll be taken care of.
They'll be taken care of.
Very important.
Immigration status, we don't care. We took care of a lot of the immigrants who came into the asylum seekers that came into the community as of late. So an individual like you described would come in, make an appointment. We get them into primary care first and foremost, right?
Okay.
We got to see a primary care provider, so that person would see an adult internist, and then get a full evaluation of everything that they need in the health center. And then we
questionnaire, fill out all kinds
we
of
have them fill out whatever we
health
can,
history,
but we do a lot of time talking to patients. What's going on? Where have you gotten care? What medications are you on? What's your family history? Just all those things that are really important for us to create a care plan for that individual, which, by the way, also includes their care, the needs that they have outside of the health center. So it's not just focused on the medical needs. We focus on the entire whole person care.
Like
So
if their kids
they're
are
homeless.
having the homeless or drug addiction or you name it, or kids having trouble with kids at home and so on. Or
all that stuff plays a role in someone's health care. When we talk about
Absolutely.
people taking care of themselves, but they're homeless or they're living in a shelter,
Right.
their priority is, where am I going to lay my head tonight? It's not so much about taking my medications, right? And so we make a very thorough assessment of those individuals. And what we try to do is create a one-stop shop. So they might see an internist. Later on, they might see what's called a care manager, a person who's going to help them to navigate perhaps some of those social programs that they're eligible for that they don't know about. So maybe they don't have Medicaid, but they're eligible for Medicaid. We'll help them find out how to get Medicaid. They don't have housing, well, we'll hook them up to housing resources. They don't have food. We have a list of food pantries in the community that we can refer them to. So we really try to envelop them in as much care as possible and get them engaged in their care.
And get to know people as people,
correct.
as human beings, living human beings, not just the
They're not-
15-minute.
They're not a number to us. We
Yeah.
spend a lot of time with them. As a matter of fact, a lot of them we know because they're from the community.
Yeah.
I would say 80% of my staff are from the surrounding community. So they know these individuals, and sometimes my own staff will send people to the health centers to get care, knowing what we can provide them there. So we get to know them very well. And again, we have all the services in one place. So the patient you describe who's a diabetic, maybe they have hypertension.
Yeah.
Well, we have a cardiologist there. right? They need pharmacy services. Well, we have a pharmacy there. Perhaps they have depression, anxiety. We have behavioral health services there.
The mental health services, yeah.
Whatever they
Very
need, we have in
comprehensive,
that place. I describe it from womb to tomb. From prenatal care all the way through the life cycle is what we try to provide. And our goal is to help these patients navigate this complicated healthcare system that we have. And it's very complicated. Even for those of us who are very knowledgeable, who work in the field, find it very, very
Why is it so complicated? Why?
It's just a very fragmented system.
Yeah, we don't have national health.
You have all different types of payers who pay for the services.
Yeah,
you have different hospitals that are part of different payer networks.
So you help them with that.
So
too.
it's not a seamless process where anyone can go into any healthcare facility. They have to go to specific locations for specific care. You want to see a specialist? Well, I got to look at your insurance company and see what specialists are in network.
But you help people with all of that
We help them with all that.
because a lot of people just, this is too much for me.
Correct.
So that's so important that you're doing it. Gee, I was just wondering, people come from Rikers. They're let out at 125th and Lex. Do you find I'm sure many find their way to your facility?
Some of them do, and some of them get navigated to us. We work in partnership with a program called Exodus, which is literally across the street from us.
Yeah, I've seen that.
They are a re-entry program that's been serving the community for 20 plus years. And we literally have people who have, we had a client yesterday, 30 years in jail, coming back into society. Yeah. They walk them over to our health center, and we're starting to take care of that person who, by the way, also has HIV and doesn't know how to access care. So we're going to really work to make sure that they get into care. The immigrants who came in recently, most of them knew nothing about getting health care.
Yeah.
We had...
Or afraid to even walk in anywhere.
They're afraid to identify themselves because they're fearful of getting, sort of sent back to their country. And what we do is really open up a sort of welcoming environment to them and provide them the care, what they need. And beyond that care, right, we provide them with food, we provide them with clothing, we provide them with access to so many different resources. And that's the beauty of a community health center like ours. And many FQHCs in this state, in this country, do those extra things, what we call enabling services. Those services that, by the way, are not reimbursed by our health insurance companies, but they're critically necessary.
You're very much dependent on federal monies?
Absolutely.
State monies?
So federally,
mainly federal.
Mostly federal. We are under an appropriations from the Congress, for the Community Health Center.
Is that always a hassle, a struggle?
Oh, every year you got to go. Every year,
you got to go.
Congress has to go through appropriations and make sure that they appropriate dollars. For the first time in 7 years, we got to increase the appropriations to FQHCs for the first time in 7 years.
So that's part of you go out and testify and
I was
grilled.
Yeah, no, I was in Washington D.C. early in February, visiting our elected officials and really making sure that they understand our story, they understand the work that we need, they understand the value that we have. When you look on the return of investment of FQHCs, we stretch a dollar way further than anyone can.
Much, in terms of cost benefits, rather than putting someone in an institution. Obviously, that makes so much more sense. And just at a humane, moral level, but also you're creating a sense of community and a healthy community.
Correct. That's
going to be a more loving, giving, productive community. And so I imagine it's hard to make that, I don't know, do politicians really see that, or is it all is there kind of?
I think some do.
We
have some really supportive elected officials in East Harlem.
Want to name names?
Should I? I don't know.
Why not?
Is that a good thing to do?
Well, yeah, especially if they're supporting.
Well, one of our city council member, Diana Ayala, has been tremendously supportive of us over the last several years.
Good.
She bleeds East Harlem. People like that really get it. We have Assembly Member Eddie Gibbs, who's been working with us as of late. Formerly, we had the Secretary of State, Robert Rodriguez, who's a big supporter, continues to be a big supporter of ours. Cordell Clear, a senator as well, who's been very supportive of us. Jose Serrano has also been supportive of us. We have the Community Board 11, Xavier Santiago, who's been very supportive of the efforts and shines a light, tells our narratives, gives us the opportunity to get in front of people to help them understand the work that we do, because I think many people don't get what we do. They don't understand it.
Why don't they? What is why is there such a gap? I mean, it seems so logical. These are things that you shouldn't have to even debate about.
Yeah,
I mean, what is the problem? What's the disconnect?
I think when they learn about it, there's no debate. I think the
Right.
problem is that we have to tell our narrative. We have to tell our story. And I don't think that we've done a good job of that. We just put our heads down and we get the work done. But one of my roles now as the CEO for this organization is to make sure people understand what we do in that building on 123rd and 3rd and the impact that it has on the community. And I've done a lot of work to make sure they understand that not only do you get good care there, you get great care there.
Mm-hmm.
We have these things called quality metrics, right? We look at how we do with certain kinds of conditions for patients who come through our threshold. So hypertension control, right? Controlling blood pressure, controlling diabetes, controlling asthma. One thing we have not done is laud the work that we've done in that space. When you look at our quality metrics and you look at our dashboard as we describe it, I put up against any academic health center. But we as health centers have not focused on putting that story out
doing
there.
that. So you've been keeping these records the last few years, and so you've been so busy. So this is the
decades.
time, the decades, to get them out there. So yeah, how about church support? Are the religious leaders?
I mean, we work with
behind
our community-based organizations, and they'll send us parishioners, or they'll ask us to come in and do screenings within their churches, which we always do. Anyone who asks us to come out and do something at the community-based organization, we do. We have actually created a very large marketing, communications, and community engagement department that goes out through all throughout East Harlem to get folks engaged. And not only do we promote our services, what we try to do is also share other resources, because we can't do it all.
Yeah.
Healthcare in this community.
But you're the largest. Are you?
We are a fairly large health center. There's a couple. So in East Harlem, there are 4 other FQHCs. So, so ourselves, Boriken, there's Settlement Health, which is only 2 blocks away from here. They've been in the community quite some time. Institute for Family Health, they're on 119th Street and Madison Avenue, the old North General. And there's VIP Services is another one that focuses on the very specific populations. And then as you move out, there's others in the community, but the 3 of us, I think, are the largest providers of community health center services.
Is it Hunter, the School of Social Work?
They're up on 119th Street, yeah.
Yeah, so isn't that sort of also possibility of having some of the students intern there?
We've looked to collaborate with them, and we've had some interns there. We collaborate with anyone who is mission aligned with us. If you want to help this community, then let's lock arms and let's do it together. Because as I was saying, this is not a one-person show. One health center such as ours, we're making a dent, but when you look at East Harlem as a whole, and you look at these things that we call health disparities, they haven't really changed significantly, right? So
they haven't in the 30 since the 60s. Are you saying?
Well, since we've been recording it, because when I was a kid growing up in East Harlem, we didn't talk about health disparities. We just knew that people in this hood, as we describe it, had different healthcare outcomes than people in the next neighborhood, Upper East Side. We knew that anecdotally from seeing it, from witnessing it. We knew people were dying younger in our communities. It wasn't until David Satcher, who was Surgeon General, really framed the health disparity issue and sort of defined it. And so now we have a definition of what a health disparity is, meaning a difference in healthcare outcomes despite equal access, I'll put that in quotation marks, access to care, right? And so for the last 20 plus years that we've been measuring health disparities, when you look at the overall health disparities of East Harlem, we haven't really moved the needle. Now, the 12,500 patients that come to my health center,
you have moved.
We have to move the needle.
So which obviously then means more of what you're doing.
Exactly. So what happens to the other 120,000 individuals in this community? So Settlement is doing impact.
So you're dealing with about, what did you say, 12,000?
No, so we take care of about 12,500, but East Harlem, as you know, has about 127,000, 124,000 residents. So how about the rest of the East Harlem?
Yeah.
And the way that we're going to have to do that is through more collaborative efforts. One of the other things that you talk about complication in healthcare is that we're very fragmented, we're very siloed, right? We don't work together as organizations in the way that we should. People put their blinders on. I'm going to take care of the patients that cross through my threshold. I'm not interested in what's happening at Metropolitan or Mount Sinai or any other health institution. But that's a very flawed approach when you're talking about the population of East Harlem. And so that's the big focus in medicine. It's not just individual health, it's the population health. How do we raise the population health of the entire community and not just individuals? You do it individual at a time, but there's programming, there's things that we could do collectively that help to address the entire population.
And obviously, we're not back in the mid-60s. We don't have a great society, war on poverty. So, and there are all kinds of, as you know, political reasons for that, and the pullback on that, and so on and so on. So when you go up to Congress, when you go testify, who you're trying to convince who? People in Kentucky and who have their own health issues, but do they know what do they make of what you're asking them?
Yeah, I mean, I haven't had the good fortune to be
I just made up a
invented
state
to committee, but
Yeah.
when I've gone to when I've gone to DC, I focused on our elected officials here in New York,
Right.
to make sure they understand what's going on in their districts, the value of what we do, and then
Yeah.
you would hope that they become sort of now the megaphone,
the catalyst.
for what we're trying to do nationally. And it's had an impact. Like I said, for the first time in 7 years, we got more appropriations for community health centers.
Right, I picked up on that. But
So-
again, what you're really talking about, and well, correct me if I'm wrong, what we were trying to begin to do with the Great Society programs, which got short. We cut them out. There was a backlash, and what we needed to do is expand and have more of these facilities,
Correct.
not less.
Correct.
But again, you're dealing with that mentality of opposition. Help us understand, help the audience understand that. Why is that such the case? I mean, other countries take it for granted. Healthcare is a right.
Correct.
National health insurance and so on, so on, so on. Why are we?
I think there's still a philosophy of this sort of,
Free
handing
market
things
stuff.
out. People have to earn stuff, and not
The
understand-
deserving poor.
right, and
business.
not understanding the plight of what it is to grow up in a community,
Or
like this,
caring.
the challenges that
Yeah.
people face to get to where they are. It's just a very sort of short-sighted view of this that is antiquated, quite frankly, and they don't understand the return on the investment. When you talk about healthcare dollars, you mentioned, right? We lead the world in healthcare expenses as a
Yeah.
country, yet we don't rank number one.
And you're right.
We don't even rank in the top 10.
Right.
But we have the most
Life expectancy is what, 30 or something?
we have the most per capita expense on healthcare, yet
Right.
where we expending those dollars is the problem. We're expending it at the wrong sort of lever points. We need to expend those dollars on the preventive part, the primary care part of it, and include what we also recognize now are equally impactful, and those are those social issues that impact health. When we talk about poverty, when we talk about food insecurity, when we talk about crime rates, those things equally, if not greater sometimes, impact someone's health, and we need to start to invest in those sorts of things. Housing is a right. Healthcare is a right, and they have to be combined. Otherwise, one without the other is fragmented.
You're pretty amazing. I have to say, as I listen to you, I mean, you got an MBA from Harvard. You got, I don't know what is your medical practice?
Listen, I'm a kid from East Harlem.
No, I know, but you're
know.
at the same time you have to be a politician. You have to a sociologist, understand, economist, and I notice over and over again, you're appealing to some of the hardline opposition to the economic argument.
Correct.
But still, even if you make that, there's resistance that transcend your logic. Hey, this is the way that you want to save money? It's like, no.
Right.
They do and they don't. Well, we know that people get worse in prison. So if you try to appeal to people and say, what you're doing is so counterproductive. You're creating better criminals. Well, yeah, but no. We're going to vote for increased budgets, put more people in prisons.
Right.
Rather than halfway houses or
Right.
whatever. Difficult dilemma. It's not just you facing it, but So again, you appeal at this economic level very skillfully. I mean, but still, what do you do with people who hear that message and say, well, nice meeting you and good luck?
Well, if those people are people in power,
Yeah.
we hope that your voters out there, wherever you are, make a decision and put the right people in power.
That's
people
right.
who understand what's going on. And something inherent in all this that we have not talked about is just, who are we talking about? When we talk about these underserved communities, we're talking about Black and brown people many times, right? And so we haven't talked about institutional racism and structural racism that has gotten us to this point. And so those are the barriers that we need to eliminate, because with those barriers, no matter what we talk about, they're always going to be pervasive, these issues. So we need to start acknowledge that it exists without blaming anyone, but say, this is existent. These policies that we've put in place are meant to keep people suppressed. We need to change these policies and recognize that with these changes, we're going to have a better society overall.
Well, but that's woke culture here. Governor DeSantis, that's not going to go very far. But
we don't even want to go about woke culture,
right?
Because to me, woke culture is such an asinine term to me, because woke culture, I want to know my history. And if that means I'm being woke, then hello, I should have woke up a long time ago.
And they need to wake up to hear it. But that's the thing. That gets us, they don't want to hear it, because that means they have to take at least part responsibility. And it should be a big part of why people are in the situation.
And no one's blaming them for us being there. We're blaming them for keeping us there, right? So you weren't responsible for these policies, because these policies have been existing for a century. But you are responsible for changing them now, right? And if you stand idly by, right? So silence is compliance, right? So you have to wake up and change these sorts of policies and realize that I'm not trying to blame you for this, but this is where we are as a society, and how do we change it so that everybody has the opportunity?
That's the moral argument you appeal. And they might come back and say, well, people have to learn, that part of their reason they're in the shape they're in, or what they're doing, is they're being irresponsible. It's not. We were talking right before obesity within the community. I mean, America generally, but what is that about? It's about not having the access to healthier foods and corporate control of Burger King. I mean, look, once in a while a Burger King, well, I haven't had any, I haven't had one in 5 years probably, but the point is, not on every corner. Taco Bell or whatever. And you can go up and down the avenues and you see nothing. So it's blaming the victim again. That was a term that we used to.
And I want to go back to that. Go ahead. Because I think that's really important, because people talk about your responsibilities. But first of all, do you know what it's like growing up in a neighborhood like ours? That's number one. Secondly, I've never met anybody in my life as a child who said, I want to grow up to be a drug addict. I want to grow up to be homeless. No one ever has that aspiration. Right? There are certain circumstances in your community that lead you in these directions, right? And so in a community that's under-resourced like ours, there's no one to sort of pull people back away from that fringe as readily as other communities, right? And when you have generations that have been oppressed, it's hard. Like, I had this daring dream as a kid to become a doctor. Despite the fact that my father had a 4th grade education, my mother had a 6th grade education, and I was number 6 of 7. And there was not one single doctor in my community that I could look to and say, oh, I want to be like them when I grow up. And so as I traversed this public school system of ours, which I love public education, but there's some people who shouldn't be in public education. And there were teachers who told me I shouldn't aspire so high. Imagine hearing as a 12, 13, 14-year-old kid, when someone asks you, what do you want to do? You say, oh, I want to be a doctor. And they tell you, don't aspire so high. That could be very deflating. And when you don't have anyone else supporting you, had I listened to that teacher, I wouldn't be on this stage with you today.
So what made the difference for you personally?
A couple things. First of all, I just believed that I could do this. I believed that.
Where'd you get that from?
My father was a
folks.
very hardworking man. My father was not an educated man, but he was a smart man.
Yeah.
And he had a lot of drive, and I liked his work ethic. He was 5 o'clock in the morning, he was in the office. Doing the work that he did. So I think that work ethic came from my dad. Seeing what I saw and wanting better for us. And if I'm being very honest, and I'm not sure if I can say this, but my badassness, it was like, listen, society says a Puerto Rican kid from East Harlem's not going to become a doctor. I'm saying,
You weren't going to say no.
Watch.
Yeah,
watch me.
right.
And
Do you have do you have two good teachers that motivated you, that sort of no?
Oh, no, I have a few.
You had a couple.
I tell people, I always remember those people who were my detractors and my supporters.
Right.
And I didn't mention the name of the teacher who told me not to aspire so high, but I often do mention his name publicly because, you know what? He said that. Right?
Well, this is public. Whatever you want. I know. But
I will tell you, I went to Wagner Junior High School, and there was a teacher by the name of Mr. Ambrose who told me not to aspire so high. And Mr. Ambrose, here I am.
There you go. Mr. Ambrose, you're called out. And don't do that anymore.
And then I had
He's not teaching.
Then there was I'm sure he's not teaching now. And then there was a gentleman who's a nurse, the only nurse in our neighborhood, Mr. Dewa Thomas, who didn't know how to guide me, but at least believed in me. And thought, say, listen, Adam, if you want to become a doctor, perhaps you should get a nursing background, which I did. And it helped me get into direction. It wasn't the end-all, be-all step for me, but it was someone who at least believed in me, gave me a gift when I graduated high school. Every time I had accomplishment, he sort of, applauded that gift. So he was wonderful. And then in college, a couple of folks there, Miss Jocelyn Jerome, I remember her very well, who put a lot of faith in this smart-ass kid who was in high school. Because I was a very good student, but I didn't have to work hard to get good grades. So I was a smart-ass as well sometimes. And so, but she believed in me, and she saw.
So if you're going to be a smart-ass, at least be smart too.
That's correct.
It's a smart and being a smart-ass. That always works better.
And then Lolita Wood-Hill, who was my pre-med advisor, who really pushed me across the threshold to apply to medical school. And then today, someone who's still my mentor works out of Mount Sinai, Dr. Gary Butts, the first Black physician I've ever met, interviewed me for medical school. And I got accepted to Mount Sinai, a school I joked about going as a kid. Growing up in this neighborhood.
Right.
Yeah. So I have quite a few of them. Yeah.
That's where that's where I go.
Yeah.
As a cardiologist. So Mount Sinai, so interesting, and so your energy, you could feel it, goes into the center also, because you can tell you've been through it. You know what it feels like.
Thank you.
And you're not separating yourself from the masses. You are with them, and you're trying to be that energy and believe in them as well. You can do this against great odds.
Correct. And I do a lot of mentoring, actually. I work for an organization called Mentoring in Medicine. I'm the board chair for Mentoring in Medicine. So we're trying to get more Adam Apontes in the world into medicine because it's not an easy feat. When you have, like I said, that daring dream of becoming a doctor, you're in a deep valley and you're looking at this mountaintop and you're like, how do I get there, right?
This is, it's true. Look, I taught over 25 years at John Jay College, so as a sociologist, criminologist, and so on. I had a great number of students, and the ones still, I believe today, who do the best, demographically there, are the Latino women. The men still seem to drop out in much greater numbers. Can you explain a little of what's going on there?
It's hard to know everyone's situation.
Sure, exactly.
But I'll tell you this: as a young man growing up in East Harlem, right, there were a lot of things that distractions, because when you're growing up poor in this community and you're trying to, just have a nice pair of shoes, a nice pair of sneakers and whatever, and there's no opportunities for that. And there's no one there who has shown you the path to success. Young men in particular get lost because they get caught up in a lot of these situations, because they're trying to,
just survive.
Just survive.
Get by.
And I think that they are more vulnerable in many respects to these sorts of influences from peers and things like that, just to get along. There's a certain way that if you're living in these hoods, sometimes you gotta be a little bit tough. You gotta, whatever. I remember being called a punk for going to school.
And doing well.
And doing well, yeah. But I was fine with that because, I was able to balance.
You were sort of, in a way, a traitor to the streets. And why are you playing this game here?
Right.
You know that you're not going to get anywhere with it. And that mentality.
They had not seen it before. They hadn't seen it.
Exactly.
Right.
It's so you are such an important role model, and need so many more, so that these young kids do see that.
Well, it's one of the reasons I became a pediatrician. Right, so in medical school, my first year of medical school, I loved science and whatever. I didn't know what I wanted to do. I thought I'd do surgery because I'm a very spatially adept person. I use my hands a lot, as you can see, and I love surgery. I loved anatomy. But I had an experience as a first-year medical student working with my mentor, Dr. Gary Butts, in something called the Adolescent Health Center, which still exists from Mount Sinai. It's on 94th Street now. And I was a first-year medical student.
I picture 94th and what avenue?
94th, just off 2nd Avenue. It used to be, though, on 102nd Street in Madison Avenue when I was a student.
Okay.
And Dr. Butts was seeing a patient who happened to be the younger sibling of a friend of mine from the neighborhood. And he saw me and he said, "Adam, what are you doing here? What's going on?" I was like, "Yeah, I'm going to medical school." He's like, "What? I can't believe that. Wait till I go back to the community, the hood, whatever." The D was called Washington Projects. Shout out to Washington Projects. Not that I lived there, but I had a lot of friends there. There's a place called the D. And he said, "Oh, wait till I go back to the D and tell everybody you're going to medical school. Yo, that's dope." That kind of thing. And it was like an aha moment for me. It was like, you know what? I got into medicine because I want to improve the life of my community. But not can I only do that, but I could also serve as a role model. And so when I was seeing patients, I don't see patients now because I'm an administrator now. Every time I talk to kids, I always talked about, so what do you want to do when you grow up? And I didn't care what they told me. I never dismissed that dream. I don't care what it was. And, a lot of the kids come in, they want to be, a baseball player, they want to be an NBA star. And we know it's easier to go to medical school than to become an NBA basketball player, for sure.
Absolutely.
Right? But not one single kid did I ever kill that dream, because LeBron James told his pediatrician that one day. Right? Michael Jordan told his pediatrician that.
But you should also tell him just what you just said. Hey, have that dream, but realize the chances are very, very slim. So, hey, fall back on maybe.
I don't say they're slim. What I say is that, do that. But what are you doing today to get there, first of all, right? You can't just be thinking about this casually. You got to work towards it. And by the way, always get yourself a great education.
Yeah.
Because it's very difficult to get into these fields.
From the beginning.
Education is always the foundation. I can leave New York today, go to California tomorrow, I have a job by Friday, because my education follows me wherever I go. And so I was impressed upon, those young kids who had those dreams, but never a dream killer, because there's a lot of wonderful children out there that are going to do some great stuff.
Let's dream a little bit here. What are some of your needs? What would you wish list? What would you like to have more of in your facility, in the center?
Well, I think one thing.
What would you like to see happen?
Right. So let's go back to reimbursements, which are really flawed in New York State. So many people don't know this. So we're a big Medicaid provider. And while we get an enhanced Medicaid rate from the state, our rates are still based upon 1999 cost factors.
Wow.
So
1999?
1999. So think about a quart of milk in 1999 and what a quart of milk costs now. So we get 70 cents on the dollar. So one of the big things that we were pushing this year with the state budget that just passed was rate reform. We need to increase our rates because, as I described to you, I do so much more for a patient than just the medical encounter, right? All the other things that we do that are not reimbursed, which are equally as valuable, if not more valuable, we don't get reimbursed for those enabling services. In order for us to afford those enabling services, we got to get the right reimbursement rates. So that, to me, is number one priority.
Did that happen, by the way?
It did not.
It did not pass with the...
It did not. I mean, we have some great advocates up there, Senator Rivera, Gustavo Rivera, Assemblymember Amy Paulin. They're big, big advocates for us. They've been pushing for rate reform.
So the governor
between the governor and the different, state and Senate, we couldn't get it pushed this year. But we're going to continue pushing.
Is it getting closer?
Each year it gets closer. But, it's 2024. We need to get there already. We can't just keep getting closer.
No, we can't. And we don't want to wait till you have as much white hair as I do here before.
You earned every single one of those hairs.
Yeah, well, maybe a good part of them. But seriously, how do you accelerate the process here? But you said before, get the people in to vote.
Get the people there. I work a lot with this position as CEO now has made it a very political position for me. I'm working with elected officials. I'm making sure they have the information they need to take back to the state legislator and understand what we're doing. We give them stories of people that we take care of, because that was very compelling. Like, look, I'm not just asking for more money just to get more money. I'm not looking for a shiny building. I'm looking for just practical services to take care of our patients. And by the way, here's what we've done. We invite them to some of the events that we do and show them and demonstrate to them. So I think that's one thing that is really big. And that's going to be a pivotal piece for us in order to continue doing the work we do. Then beyond that, there's more service needs in this community, right?
Such as?
So mental health services.
Mental health over
services.
and over
so
again.
we cannot meet the needs of this community in terms of mental health services.
What are you rates of depression, anxiety, psychosis,
substance use disorder,
substance abuse?
All these things fall under behavioral health spectrum. And we're not doing enough for this. And this is something now, people say there's more mental health in the community. It's always been here, but this community has always had a stigma about, going to a psychiatrist.
Exactly. That's another thing to break down, or try to break that stigma down.
Mental health is part of your whole body health. You got to take care of your mental health. We all go through different periods of time in our life where we may feel a little down, a little depressed, a little anxious, right? And we need to address that equally as much as we need to address our hypertension, our diabetes, our asthma, and all the other conditions that we're much more, knowledgeable about. So that's another big piece for us. One of the things that other strikes me as I sit and look at our community, the number of young people who are enabled or disabled. So, when people have injuries in this community, for various reasons, it's important to get good rehabilitation medicine available to them. And with that, they can get back to a normal functioning. Too many young people in this community do not gain access to physical therapy, occupational therapy, things that will help them to regain some of their function prior to,
their sense of identity and ego and so on.
And so they start going down this vicious cycle of, now I can't do this, now I'm depressed, and now I further, then I become obese, and then I further become, so it's a downward spiral. So those types of services, I think, are important to us. And then finally, I talked about this early in our discussion, we need to break down these silos of the way that we work as community health centers, work collaboratively, where my philosophy is there should be no wrong door. Any patient who walks into any healthcare facility in this community, it doesn't matter where their primary care provider is, we take good care of them. We get them back to their primary care provider, because that's really important. Everyone should have a primary care provider. But if they happen to walk into any door here in East Harlem, we collectively, as a community, take care of them. And until we do things like that, that population health, those health disparities, we're not going to make any changes. So
you're all competing. You're not in different, as you say, different silos, not really talking. And so maybe the patients are going here and there, back and forth. And, we saw this patient, but nobody knows about it. And wow, it's got to be much better coordinated.
And the reimbursement model creates that sort of style. It doesn't promote the collaboration I'm talking about, because there's no reimbursement around that type of collaboration. There's no financial model around that collaboration. And so we need to create a financial model that demonstrates that collectively we all taking care of this community as a whole, and that keep our doors open and we can continue doing this work.
Well, it would seem to be the interest of the other facilities to work together for this. You all would benefit.
And we do some level of collaboration, much more so today than we did, 10, 15 years ago. But it's still not quite at the level that I envision it. And that's my vision. That's Adam Aponte's opinion.
Well, it sounds very helpful. Sounds very good. No, but again, the money aspect would alleviate a lot of the concerns, I think. A few minutes we have left, I just want to throw out, there's also, what's your position on drug use? I know that there are a couple of controversial offices that have opened up that are working with various professionals and finding out what sort of drugs, least harm community efforts.
Mm-hmm.
What about the drug war legalization?
Mm-hmm.
Do you think that that's more the route to go, to not make it a public health issue rather than a criminal justice issue? And I'm just saying this. After this show, I'm running up to a friend who I've had on the show a number of times, Carl Hart. I don't know if you know, the neuroscientist up at Columbia, who has recommended the legalization of all drugs for adults and the need for education. Mm-hmm. And that, what does your facility try to do dealing with the drug issues?
It's been a very interesting, I guess, progression over the last years around how we treat drug use and how we treat individuals who are addicted to drugs.
Right.
Just like I said before, as a kid, I never met anybody who said, I want to grow up to be a drug addict, right? People don't make that conscious decision necessarily.
Right.
It's a victim of their circumstances, of exposures. I mean, we saw that with the Vietnam veterans. They all came back, right? They were all addicted, not
heroin.
by their own
they found
choice,
there.
but what they found there, what they were exposed to. And then they came back with no support whatsoever.
Right.
And so you can use that same analogy.
Or the Iraq veterans, too.
Same analogy here in East Harlem, right? And so it's clearly prevention in our young population, making sure that they don't go that direction, supporting them to make sure they don't go in that direction. That is key to me. I think decriminalizing marijuana was a great move because it created too much adversary between, sort of animosity between police officers and the community, which already exists already, right? And so let's take that away from it because you know what, there's a lot worse things that people could be doing than smoking a joint on the corner, right? And so I think some of that is important, and then not being so critical of people who are exposed or who have addiction, but being more supportive of them and helping each person in an individualized way get to where they need to get to. Right? It's not this one-size-fits-all philosophy. Every individual needs a different level of support to get them into becoming a more functioning member of society and to help overcome their addictions.
And not make it such a moralistic issue, but it's, as you say, the social factors and the understanding of some of the lack of legitimate opportunities and so on and so on. And the desperation.
What led to it, what continues to support it, what surrounding environment continues to sort of really push that forward. We got to understand all those nuances.
That's a very different conversation.
And not just saying, this person, one of my first courses in medical school, we went to the Bronx VA and there was a group of students, first year medical students, we're all like, we know nothing about medicine, right? And I was the only brown kid in the class. And they brought this gentleman who happened to be addicted to drugs. And he talked about his life. He was telling his story. It was Introduction to Medicine. And when he left, my preceptor asked, what do you think about this individual? So a lot of my classmates were like, oh, this guy made choices in his life. He deserves what he gets.
Really?
And I was the only one who said to him, I'm sorry. I said,
wow.
I'm sorry, but I don't think this guy made a conscious decision to use drugs. I don't think this guy want to grow up to be a drug addict. I don't think this guy wants to continue living that lifestyle because there's nothing luxurious about it. Right? So why are we being so judgmental about someone like that? And I think that we need to recognize that in every individual.
Even at this highly educated level with your fellow medical students or whatever, the comrades, that mentality is.
Well, I have a different perspective growing up in the hood, right, than compared to some of my classmates, seeing this stuff firsthand and witnessing how these things evolve. And when you don't see that and all you see is news clips of, this and that, and then you have a very different perspective on what that life is about.
But they also must have some sort of experience with understanding the over-the-counter prescriptive addiction that so many upper middle class women are. Look, the drug abuse that exists among the very rich, you go down to Wall Street, and half of them are bouncing off the walls.
Right. And that came a little after the oxy, but still, So it's just it's a matter of creating that awareness around people, understanding, and just meeting people where they are, and not being so judgmental, and helping them get to where they need to go. And sometimes it takes a couple of different attempts because people are not always ready for change. They don't have the support structure around them to be able to accept change. There's a lot of guilt within themselves. There's a lot of self-esteem issues that have to be addressed. So it takes a lot more effort to do this. And I think that's the other part of it, right? It's not an easy fix. I don't give you a pill and you're fixed, right? It takes a lot more services and you know, intentionality and support to get someone to move that. And I think that's been a big challenge for us as a society, wanting these quick fixes.
I've got to ask you, how do you keep your buoyancy, your positivity, positive energy? I mean, it's just amazing. I just admire and respect it so much. I mean, I'm not putting you on some sort of pedestal here, but man, you have fought some big struggles here.
You know, I'm doing what I love.
That's
right.
I'm
doing what I love, and it was this childhood dream of mine to just to become a doctor. Forget about where I am today. Just to become a doctor, and accomplishing that to me was amazing. And now I have so much gravy on my plate that I feel very blessed every single day the I work. I'm running a health center in East Harlem, the community that I grew up in. Right. That's just way beyond my big dreams that I thought were big at the time.
Yeah.
And so, you know, it's just, I feel very blessed. I feel very fortunate. I feel a sense of responsibility to my community. And I feel like I have a platform today to be able to really make a difference. And I'm going to seize upon it.
And you are, and you're doing it. And as colleague Cornel West would say, keep on.
Keeping on.
Keep on keeping on and stay strong.
That's right.
In the faces. One more minute to go. Any final words that we haven't covered or?
No, I think we've covered a lot. I think that my message to your listener is, listeners are, first of all, if you don't have access to healthcare, find a community health center in your community. They're all over. They're easy to find. You'll get great access to healthcare when you need it. I think that's really very, very important. Make sure you have a primary care provider. See your providers regularly. Just because you don't feel that high blood pressure, it's still there. It exists. And let's start taking care of ourselves and taking care of our community, and we can change this game.
Absolutely. Doctor?
Thank you so much.
We're going to take your advice. Thank you so very, very much for being on the show.
I appreciate the time.
I look very, very much forward to visiting.
Yes. You're going to be pleasantly surprised at what you see there.
Well, I look forward very, very much. I'm sure I'm going to love it.
And we welcome all you listeners to come back. East Harlem Community Health Center, Boriken Neighborhood Health Center on 123rd and 3rd, 2265 3rd Avenue.
123rd.
See you there.
We'll be there. Absolutely. We'll see you there. And we'll see you all next week on The Radical Imagination. Jim Vrettos here. See you next week on The Radical Imagination. Thank you.